We have to start on time, even if the conference hall is not full. So I'll do the opening remarks, me and Dr. Maher, and then we can start our first session. So distinguished guests, esteemed colleagues, and dear friends, it's my great honor as the president of the Jordanian Society of Obstetricians and Gynecologists to welcome you all to this important Fetomaternal conference. We're privileged to host 9 distinguished international experts in fetomaternal medicine. Your presence here, Dr. George, and the others in Amman enriches our meeting, and we are grateful for the knowledge and experience you bring. And for my dear colleagues, this gathering is a celebration of our shared mission, protecting mothers and their unborn children. In every consultation room, in every delivery ward, our work is not only medical, but deeply human. The science we learn and the skills we refine translate into healthier families and stronger communities. This conference is more than an academic exchange. It's a reminder that collaboration across borders and generations is the key to progress. Together, we can raise the standards of care, embrace innovation, and give every woman and every child the best start of life. On behalf of the Society, I thank the organizing society and special one to Dr. Maher Maaita. I thank our international speakers and all of you making this event possible. May our time together be fruitful, inspiring, and memorable. Thank you very much. بس في ملاحظة بليز، بدي من جميع أعضاء الهيئة العامة للنسائية والتوليد القيام بتسديد الاشتراكات السنوية ل 2025 مشان أن انتخابات بشهر 12، ولازم يكون كل زميل، وبليز خبروا زملائكم يكون مسدد للنقابة حتى شهر 7 2025. Thank you very much. Dr. Maher.
Thank you, Dr. Abir. On behalf of my colleagues in the Jordanian British Society, we would like to welcome you to this Congress. I hope you'll find it useful. Thank you for our international guest speakers for taking the time and joining us here and supporting our Congress. As you can see from the program, we have a variety of topics covered. We have live scanning sessions in the late afternoon on today and tomorrow. I hope that you'll find the program useful. Hopefully, I think from what I heard from Hanan, we have 220 people attending the Congress, but usually early morning and people are still sorting out a few things. Anyway, welcome our guest speakers again. Thank you for coming. I hope you'll enjoy the meeting, and we will start the first session. Thank you very much.
Okay. Sabah al-khair al-jamia. Good morning, everybody. So it's really a huge pleasure to be with you, and really I appreciate every time I'm arriving to Amman from the airport to the airport. It's mean that really I'm enjoying every second here in your country since my arriving till I'm leaving this beautiful country. And I wanted really to express all my knowledge a lot of thanks to Abir and to Maher, because every time we have a lot of things to see here in Jordan, and a lot of things to learn, not just in medicine but in everything, even in human right and exchange with people. And this is why I'm always happy to be here. So they asked me today to see to speak about heart exploration in first trimester. As you know, in ultrasound, there is several questions to ask before we discuss this topic. First of all, do you think that all what is visible have to be checked? If yes, we'll spend at least 2 hours for every ultrasound scan. The aim is to have a routine ultrasound scan and to have a screening for everybody, every people living everywhere in every coin of your country and mine. But to be efficient, screening should be organized. How to be organized? We have to see what the WHO have said. They said that you have to screen to high prevalence of disease, and the tests have to be safe. We have to be able to have a second level test, what we call an ultrasound diagnosis ultrasound scan. We have defined an effective management of real positive. The patient have to be informed of the issues and limitation of the test we are doing. And for sure we have to adapt the screening to each country, to each characteristics of country, legislative criteria, cultural, economic. So in France, like in United States or in England, we have also our recommendation. You will see that recommendation of the French College in France are really the same thing with the ISIOG or with FMF or with American Society. So there's just little difference, but in the facts, it's always the same thing, and we have always the same evolution in first, second, and third trimester. So today, I speak about the first trimester, and in first trimester, I speak about heart disease. Why heart disease? Because as you know, all congenital malformation is about 2 to 4% of fetus, of pregnancy, but 1% is for heart disease. Between 0.6 and 1.3, we see 1%. And often it's an accident, and 70% of cases are in low population. So it's really the definition of screening. It's to see the low population, the low risk population. What are the high risk population? We'll discuss this after in the finished. It's when you have an NT more than 89 percentile. If you have a family history, for example, a history of congenital heart disease, if there is 2, you see the risk that you have another congenital heart disease is more than 10%. If you take teratogenic like diabetes, lupus, PCK, rubeola, alcohol, or lithium. So, why you have to check for CHD? Because it declined in neonatal mortality. As you see this example for transposition of great artery, we have taken 250 transposition of great artery in neonate. And you see, if you do the diagnosis in prenatal, the time of admission in the hospital is 2 hours. If you do the diagnosis in postnatal, 73 hours. And especially, look here, the pre-surgery mortality, if you do the diagnosis in postnatal of transposition of great artery, is 6%, and post-surgery is 8.5%. But if you do the diagnosis in prenatal, 0% of prenatality, of mortality, excuse me. 0%. You see the difference? This is why you have to do the diagnosis, for example, of transposition of great arteries in prenatal. It changed a lot for the babies. And also, you have to do the diagnosis in prenatal because it helps you to detect chromosomal anomalies. It helps you to detect other polymalformative affection. You know, CSG with other anomalies, 30% are not isolated, and you have, can I have just? I will not speak a lot of embryology, but just to show you how it happens. You know, in prenatal, you have in the heart, you have like a tube of heart. You know, this is a conus truncus, and as you see in the feast, people can do something with the balloon. So it's the same thing in the heart. The heart will begin like this in the tube, and then there is transformation of the future arterial trunk, the ventricle, the atrium, and they're going like this. And especially, and this is very important, this is why I have taken a bottle of water with me, especially I always explain that the vessels, the great arteries, when they come on the ventricular, is like this bottle of water. You take this bottle of water with your two fingers, okay, and you put it on the bottle, and you have to turn 180 degrees like this. You will have the vessels like this, okay, and the bottle is now closed. If you turn the bottle, there is no water to go. But if you take this and you turn just 170 degrees, and I turn, this is the defect septum, defect septum. But if you turn just 90 degrees, then you have a fallow disease. And if you don't turn, you have a common artery. So it depends. And remember, with this bottle, always that you have these two fingers are the great arteries. This is the aorta, and this is the pulmonary artery. Remember every time. The pulmonary artery is always longer because she takes place from the right ventricle. And the right ventricle is always anterior. And he go to the aorta with the ductus arteriosus. This is why it's very long. And aorta is less long. So remember this. You have to turn, and this is not very long. So it would help us a lot in first trimester, as you will see in few minutes. So to resume, the echoanatomy of a normal heart is very easy. You have right atrium and left atrium, right ventricle and left ventricle, pulmonary artery and aorta, and there is a shunt from right atrium to left atrium with a bottle hole, and from pulmonary artery to aorta with the ductus arteriosus. In fact, it will be easy like this, but in reality, this is what you have in heart. So, long time ago, since 2000, we thought that because of the heart is really parallel to diaphragm, the first thing to do is to have 4 chambers view, and the 4 chambers view is really parallel to the diaphragm. Just you go from the diaphragm to the 4 chambers view. And to have the 3 vessels, you have to go to this plan and to turn 30 degrees. This was 20 years ago. Now it's always available, but you have changed a little bit, as you will see all this day. So the French college decided that we have to speak about heart. So the first thing is to see the location, but especially if there is a heart activity, a cardiac activity, and if the heart rate, you have to measure it. If it is, and say how much is it. If it's abnormal, it's normal, you say just everything is okay. And usually you take the heart rate on the tricuspid. Why? Because tricuspid, because you see here the profile of the tricuspid is like an M and asymmetric M. It means that normal. This is normal. There is no regurgitation. This is a normal view of tricuspid contraction. As we decided everything, every time you do a scan in prenatal, you have 5 parts in your reports. In 12, 22, and 32 weeks, we have always 5 parts. The identifications with an S, the identification of the person who do the exam, the physician, for sure the patient, and also the machine. And in France, you have to write the age of the machine. The first time you have used this machine, not used the machine. The first time that machine have been put on the market. For sure, initial information about last menstruation, date of beginning of pregnancy, if it's known, gestational age, what you have found, and you have to specify it if you have done the exam, transabdominal scan or endovaginal exploration, the iconography, and in French college, we ask you to have some images I will show you, and the conclusion. The morphologic item in first trimester are 13, as you see here, but for the heart, there is just 2 things asked: normal position of heart and usual aspect of heart cavity. It's mean 4 chambers view. Okay, this is just the two items that you are obliged to write in your first trimester scan. You know, in France, if you don't have one of these items, you are obliged to ask someone else of you to do the scan, or to see the patient 1 day or 2 days after to do the scan, or to do the scan in transvaginal if you don't see in transabdominal plan. So if you don't have these 13 items, you cannot consider that your exam is finished. And in France, for first trimester, we ask about these 8 pictures, and as you see, you have the picture of heart, but also the picture of stomach. Why? Why it's important for heart exploration? Because the abdomen plan with the stomach will give you the right and the left of the baby. So if it's normal, the stomach is always on the left, and if it's normal, in the thoracic plan, you have the heart, the point of heart, always on the left. So it's easy to put. And if we consider that if you don't have, you don't have this plan, you can replace it by using color, and the color for 4 cavity views, 4 chambers view, and for the great arteries. As you see, great arteries, it's always easy: pulmonary artery and ductus arteriosus and aorta. Remember the two fingers. So fetal heart exploration is easy. Look what you have to see every time you do check. All this, I will not read them, we will see them, and all this. And as you see, it's like a book. This is Shawi who give me this. Like you have to explore the 4 chambers view and the great arteries. This is why we have put this slides like this. So, is it possible to have heart in first trimester? As you see here, the heart in first trimester is like a grape seed, very, very little, and you have to see the 4 chambers view on this grape seed. What are the problems at first trimester? We'll discuss. I think we have a discussion for this. Can we do it? What we can see? Which population? High risk or not high risk? The aim of exploration, if it is interesting or not, and the feasibility. Feasibility, it depends if you do the exam in transabdominal or endovaginal. For sure, the operator. For sure, the machine, the setting of the machine, the gestational age. The setting of the machine, you have to increase the frame rate by reducing the window, and you have to put less gain and less power. And you have to use a digital zoom. In 2002, Hack explained that we can have a success exploration of heart from 11 to 12 weeks, 20% of success rate, 20 to 13, 60%, and more than 13, 82%. We have done the same study from 11 to 14 for all people in France who do screening. We asked them on 15 days to tell us for all first trimester scan what if it was possible to have 4 chambers view and to have great arteries. And as you see, in these 2 weeks, for all French people who do screening in first trimester, 86% of person have a success rate for four chambers view, and for great arteries, 79%. So it is possible for screening to see the heart. We published this in ultrasound in 2017. So what we can see, as I explained in the beginning, the first of thing is to see if the heart and the stomach, the point of heart and the stomach are on the left. For example, you can see here, this is a cephalic presentation. The stomach is on the left, no problem, because it's a cephalic presentation. But as you see here, the point of the heart is on the right. It's easy. It will give you a lot of information. You have to ask to someone who knows cardiology very good. It's pediatric, for example, to help you to see if there is a problem in this situation. And especially if you, as you see, the heart on the right, it could be a genetic disease or something else. So immediately you see that there is a problem. The four chambers view, as you see, it's better and better, and about 13 weeks we can do really a very nice exam, as you see here. You see here four chambers view with cavity balance, normal cavity balance, no effusion. The heart is about 30% of thorax. Everything is okay. This is the view that they ask in the French college. You can use the color, like you can see here. Okay. And you have to look about the V, pulmonary artery and aorta. Look, it's always, look, this is a very, very old, no, not this one, another one is old, as you see here, the two vessels. This is a very old machine, medicine, before Samsung. And you see that even at this situation, we can see the four chambers view, and look, we can see also the great arteries. You see the Y, the V sign. As you see here, this is new machines. Okay, you can even do in slow flow, and you can do also in 3D, color 3D, and you can do also restriction, as you see here, four chambers view and great arteries. Four chambers view and great arteries. We have done this not at all to show you that you have to do this, but to understand how are the situation between four chambers view, the ventricle, and the great arteries. You see the relationship between the two. This is the 30 degrees you are turning, okay? Up, and you turn 30 degrees. You can see also here in 3D. Why to do the diagnosis? As you see, this is very easy. You can see here diaphragmatic hernia. So it will help you for the diagnosis. Here, univentricle heart, the atrium and the ventricle. As you see here, univentricle heart. At first trimester, you see, 12.6. You look even here, you have a linear insertion of atrioventricle valve. You know this is a sign of trisomy 21. Okay, you see. And you see you have the placenta. This is a transabdominal view. This is an old machine. And you have really here a lot of thickness, and you can see also the insertion. This is an atrioventricle septal defect, as you see here. You can see it here. For sure, you can see this in chromosomal anomalies, and especially trisomy 21. You see, I show you here a lot of pictures of anomalies in first trimester. Here, tricuspid atresia. As you see here, there is just one ventricle and two atrium. Mitral atresia. Atrioventricle septal here. defect, Epstein anomaly, and tricuspid regurgitation, as you see here. This is on the forecavity. This is the U sign instead of the V sign, and this is the Y sign. In this situation, you have perhaps a Di-George syndrome. It's been deletion of 22, chromosomal 22, the Q of chromosome 22, and this is a Fallot disease with an overriding aorta, as you see here. This here, when you are trying to do the V sign, you see here pulmonary artery, and this is aorta, and you see double color in the aorta. It means that you have a stenosis of aorta because the blood is going like this and not like that in this situation, so there is an atresia of the aorta. This one is the atresia of pulmonary artery. You know, the same thing, but the other one. So you see here the difference of colors. As the same thing like here, aorta and pulmonary artery. Here, the same thing, you have pulmonary artery, and look, the aorta is really very, very, very thin. The same thing as we have, as I show you for four chambers view, this is for the great vessels. You can see here pulmonary artery stenosis, just one arteries. This is an aorta stenosis. This is intraposition of great vessels at first trimester. Double outlet on the right ventricle, truncus arteriosus, and here another U sign, as I just showed you before. So, the interest of high risk is really codified. If you have a high risk, it means that the NT is very high. As you have history, you have to do the heart exploration first trimester. On the low risk, it's not codified. There is for sure univentricle, the U sign, the defect on septum. It's good. For the transmission of great artery, it could be not easy to do it on the first trimester, but anyway, it's not important to do it in the first trimester. You can wait for the second trimester. So this is the high risk, as explained to you. The history, if there is an ophthalmosele, if there is a kidney malformation. This is the prevalence of NT. More it's bigger and more you have heart disease. If you have a story, diabetes, lupus, as I explained just before. So in conclusion, heart examination is possible in first trimester. In 80% of cases, just by transabdominal scan. And in 20%, you have to do an endovaginal abort. You can use 2D and color energy, especially if you are after 12 weeks. Between 11 and 12, we discuss the using of color, but I think that you have another topic about this, but it's possible, and especially it's not very, you have to take it some second or 1 minute maximum, so it's not very difficult to do it. And the majority of heart defects are occur in the first trimester, and I think that most heart defects can be seen, especially the poor prognosis heart defects can be seen in first trimester, but you don't have to begin screening for heart malformation in first trimester on low risk if you don't have the network, especially if you don't have a referring pediatric cardiologist that he be capable to see the patient at 16 to 80 weeks to confirm your malformation and to study other things. And you see in low risk you have a lot of false positive, less and less. In 5 or 6 years ago we have a lot of false positive in first trimester. Actually I have less and less of false positive in first trimester. And as I told you, just limit yourself to the poor prognosis malformations. Thank you very much. And
Thank you very much, Dr. George. We have a place for one question. تفضل دكتور علاء. منورنا دكتور علاء، أهلا وسهلا فيك.
actually published a paper concerning the fetal heart in the first trimester, 2019. It was published in the Perinatal Medicine. And it was having the same conclusion that you have said. I urge everybody to learn how to do the heart and transabdominal firstly and transvaginal, because the field of fetal medicine is changing and evolving every time. So now we have the heart and the cranium of utmost importance to see it perfectly in the first trimester. As George described perfectly, we can have all the information, most of them, concerning is this heart is normal or abnormal. And this is a very important step. In our, of course, in France, it is a time for counseling and so on. In our community, it's very important to inform the patient that she has an heart anomaly. And you know the heart anomaly, even in low risk, it is considered to be very serious. She has to know that the future of this pregnancy is more or less compromised in a way. It could be adjoined with chromosomal, it could be have a complexes. So please, as George have elaborated very nicely, you have to train yourself from now to examine the heart at 13 weeks. It's time. We have been doing this, and Georgia, of course, in France, like 7 years. And now the ISOG guidelines recently, they put the heart saying that what is should be seen and what is more. So it is time that you have examination of the heart. So I congratulate you for this nice
Thank you, Ala. Thank you.
and
Yeah.
nice
Thank you.
to see
Thank
you.
you.
Yeah, just
Yeah.
one comment. What is really required from the general obstetrician to know for first trimester cardiac, abnormality or diagnosis? What is really needed? Most of the doctors in the whole really are general obstetricians. So what is needed from them as, to screen in the first trimester for the heart abnormality?
Very nice question. First of all, you have to discuss with the engineer of your machine that you have a preset of heart exploration in first trimester, because you cannot explore heart in first trimester using a preset of first trimester for CLL, for NT, and for other things. So you have to have a window, a very thin window. You have less power and less gain and a digital zoom to be on the heart. This is what you have preset your machine. Even if it's an old machine, it's not the problem. You don't have to change your machine. Even your old machine, you have to preset it for heart exploration in first trimester. This is the first point. The second point is always to have in mind where's the left and where's the right of the baby. So when you know where the left of the baby, you know where the stomach. And when you know where the stomach, you can see the point of the heart. So always we have the chance that the plane of stomach is just under the diaphragm and the four chambers view is just up. So you do the abdomen plan, and this is very nice for spina bifida. Samir will explain to you. And then from this plan, you go just up 2 millimeters more, 3 millimeters, and you see the four chambers view. When you see the chambers view, you have it very nice in 2D. It's okay. You don't have it, you use the color. And this is also important for preset. You use the color with a preset for color for first trimester. And then you have the four chambers view color, and then you go just up and turn little bit, it's 30 degrees, and you see the V sign in color. This is just all. Abdomen, four chambers view, and V.
Dr. Ala.
Yes, yes.
دكتورة ريما معلش short one go ahead. دكتورة ريما طبعا مشرفتنا من السعودية، أهلا وسهلا فيك.
أهلا وسهلا.
I just want to thank you, Dr. George, for such a beautiful. As a fetal cardiologist, I just have to combine two things. The heart scan is very important. It's in the expert hands. So to make it easy for scanning, two things. First, in the first trimester, it's important to command the function. So the squeeze of the heart is very important because if the baby cannot squeeze, this is bad. And the second thing I wanted to say, from the standard point of view, the first trimester scan is a chance for getting rid of the baby, especially if we have a hypoblast, which is a right or left heart hypoblast. So in Saudi, we see a lot who are interested in the first trimester. My question to you goes for the French regulations would say if you have a brain anomaly, you do heart, right? You have to do the heart scan.
Yeah, always
Why
heart.
not all anomalies? Because we see a lot. I mean, I would propose that if you have any anomaly, like real anomaly, not just before limb, or why don't you do the scan with any anomaly? The question goes like that. Because with IVF now, I'm seeing a lot of anomalies, right? And heart anomalies. But the guidelines came very late to say, okay, with IVF, the incidence of congenital heart disease is higher, especially if you have twins and so on. So my question, do you agree to do, I know it's not, do you agree to do scanning of the heart for any anomaly?
Yeah, very, very nice question. First of all, in France, actually, in first trimester, we asked to do the scan between 12 and 13, more 13 than 12, especially if you have IVF. Why especially if you have IVF? Because if you have IVF, we are sure of the beginning of pregnancy. So like this, you can calculate and see the patient at 13 weeks. You know, when you don't have IVF, we don't have the ovulation, you do the scan between 11 and 14 because sometimes she's at 11 or 12 or 13, you don't know. But if you have IVF and you have the first scan at 5 or 6 weeks or 7 weeks after IVF, so you are sure from the beginning, you do the scan at 13 weeks. Always we do this. At 13 weeks, more than 99% of babies, you can see the heart and you can see the four chambers and you can see the V-shape sign. So for us, all babies, even very low risk, have to have the heart exploration at first trimester. For sure, if you have another malformation, anyway, if even for example gastroschisis that we thought in the beginning there is no chromosomal anomalies, you have to do all the scan and that you do the genetic exploration. But all babies in France have to have a scan of the heart and everything else in first trimester. There is 13 items in first trimester for everybody. And just what I want to tell you, the study that we have done, you know, in France we have a lot of midwives making ultrasound. The midwives have also to do screening of the heart for all babies between 11 and 14, and especially at 13 weeks. So everybody have to do the scan. I'm agreed with you. Everybody have to have the scan.
Thank you, Dr.
Thank you.
George. Our next speaker is Dr. Sankaran. She has MD FRCOG. She is consultant in maternal fetal medicine, Evelina Women and Children Hospital, Guy's and St. Thomas's, NHS Foundation Trust, London. She graduated from the Tamil Nadu Medical University in India. She has a fellowship of Royal College of Obstetrician and Gynecologist and postgraduate certification in healthcare leadership, the Open University and NHS Leadership Academy UK. She also has CCT in obstetric and gynecology with subspecialist accreditation in fetal medicine. She will talk about complication of multiple gestations. Dr. Sankaran, please, the floor is yours.
country. I'm visiting it for the first time and I'm excited about exploring it further. What I'm going to talk is multiple pregnancies, such a big topic. And I see that there are other speakers who are sharing the load with me. So I'm just going to restrict myself to a few things that is relevant to fetal medicine practice. And it's mainly what I'm talking is based on the practice in the UK. Some of it may not be applicable to your setting. So I have restricted myself to antenatal complications because intrapartum complications and postpartum complications itself is a big topic. So broadly, we can divide into maternal and fetal. And of course, any complication that happens in singleton happens almost 2 to 3 times in twins. So they need very close monitoring and attention to their hemoglobin status from the beginning and pick up preeclampsia, gestational diabetes, and do the appropriate management. So when it comes to the fetal, like any other singleton pregnancy, they are at risk of miscarriage, prematurity, stillbirth, growth restriction, anomalies, with an increased incidence and prevalence. There are some problems unique to multiple pregnancies, like discordant abnormalities, discordant growth, and single fetal demise, where the decisions are going to be slightly challenging. And if you have a monochorionic pregnancies, because of the anastomosis, you have some very unique problems there, and which actually makes the management of twin pregnancy challenging and exciting for fetal medicine practitioners. And then monoamniotic twins and conjoined twins are an entity in themselves. So I think, the management of complications starts with picking up complications quite early on. So nowadays, the ultrasound has become an integral part of obstetric practice, and it starts very much from the first trimester, and nowhere like twins, it's more important. So it's important, we know that the first trimester diagnosis of chorionicity is more accurate, and we know the T sign and lambda sign to differentiate monochorionic and dichorionic twins. And we all know that the twin itself is more complicated than singleton, and if you detect monochorionicity, it's even more problematic. And so we are going to change the monitoring pattern after the first trimester, depending on the chorionicity. So I'll first start with perinatal death. This is the last EMBRACE report. I haven't included the recent one. In general, the birth is falling in the UK. There has been reduction in both singleton and multiple births. But what is interesting is we have got a gap in the outcome for the twins and singleton. In singleton, we are making some progress thanks to some programs like Saving Babies Live Care Bundle. But why is it not reflected in the twin mortality? I think it may be that we introduced management of the pregnancy guidelines as early as 2008, 2010 in the UK. And since then, we haven't had groundbreaking changes in the management, because everything like fetal therapy, everything was introduced in the UK even in late 90s, and it was at its peak in 2000. So recently we haven't seen much decline in the mortality rate. And also because the singleton mortality is coming down, the gap is widening. But the good news is, and we know that all the latest guidelines indicated earlier threshold for delivery, and we were worried whether it was going to be a problem. But for mortality, it doesn't seem to have an effect, because twins born before 37 weeks have better outcome than singleton. That's because we deliver most of the uncomplicated monochorionic twins before 37 weeks. And in general, the stillbirth and the neonatal death are much higher, as you can see here. So the commonest cause of perinatal death in multiple pregnancies is prematurity. I'm not going to talk about it. My colleague expert, Dr. Lisa Story, is going to touch upon this. In the interest of time, I will go to the second commonest cause of perinatal mortality, which is the fetal growth restriction. So first thing is, we need to identify on the scans what is growth restriction. And that's why we start scanning them from early on, for monochorionic from 16 weeks, and for dichorionic from 20 weeks, and also for picking up other complications. So the definition of IUGR, similar to singleton. If you have estimated fetal weight less than third centile, there is no doubt. So most of the time, we are in the gray area. So there is the ISWOG scoring, which has given 4 criteria, which is the estimated fetal weight less than 10th centile, umbilical artery Doppler more than 95th centile, AC of 1 twin less than 10th centile in monochorionic twins. So if you have 2 out of 3 in DCDA twin or 2 out of 4 in MCDA, then you will label it as growth restriction. I think estimated fetal weight discordance must be reported in every growth scan in twins. And it is a very simple calculation, as you can see here, because it helps to pick up your more complicated ones who are going to need close attention. So what do we do? First, we have picked up the IUGR, and the next thing is, we start monitoring them. I'll explain to you. And then you look at both the twins. Are they both small? If they both are small, it's not selective IUGR. So only one twin is small. Then you look at the chorionicity, which you know already. So it's dichorionic twins, manage it slightly differently, whereas it's monochorionic. Then you look at the umbilical artery Doppler, which classifies them into type 1, 2, and 3. Selective IUGR is more common than non-selective IUGR in twin pregnancies. So we know that uncomplicated, there is a recommended regime, but once you pick up complications, then you are going to monitor them closely. And if there is an abnormality in the umbilical artery Doppler, you are going to monitor them even twice weekly as a minimum. So it's management of IUGR depending on what the type of IUGR. If it's non-selective IUGR, the same principle as singletons. You look at whether there is a chromosomal genetic, most commonly uteroplacental insufficiency, and you deliver them depending on how you do it in singleton. So not very challenging when both of them are small. When one is small, then the problem comes. So do you go for the small one and risk prematurity to the big one? So we have to individualize the management plan for these depending on the gestation at which and the abnormality in the uterine Dopplers and whether the big twin is really a healthy big twin. All those things come into play. So it has to be a personalized care. So it's more complicated when it's monochorionic pregnancies because there is anastomosis there, which makes it complicated. You can't leave it to nature because if the baby dies, it leads to problem to the bigger twin who is normal. And the anastomosis are there in 90% of pregnancies and mostly it's bidirectional. But when there is growth restriction, then the flow becomes unidirectional. And this happens in about 10 to 15% of all monochorionic pregnancies. Sometimes it coexists with TTTS and TAPS. And you can do something about it if you think this baby is going to die. And that's what makes, us the fetal medicine practitioners monitor these babies closely. So if you have a selective IUGR in monochorionic twins, the first thing is umbilical artery Doppler is normal. Then you are a bit relaxed, so you monitor them weekly. And that is the type 1 selective IUGR. The type 2 is the one where you are monitoring, it's an absent or reverse end diastolic flow. So these are the babies who are at risk of death. So you monitor with ductus venosus Doppler. And these babies, you need to pick up a point where this baby is going to need delivery. The intermittent ones are more complex. They are very challenging because it's one day normal, one day not normal. And so you cannot rely on your Dopplers. And sudden intrauterine fetal death is very common. That will lead to neurological problems for the bigger twin. So these are sometimes, even in the best hands, there have been adverse outcomes. So what do you do? If they are at a stage where you can deliver them and look after them in the neonatal care, you deliver them. So that depends upon your neonatal care facilities. In the UK, generally after 30 weeks, we are committed more towards delivery. Between 26 and 30 weeks, it depends upon the weight and the condition of the smaller baby. So there are times when we know that, if we deliver, we are going to risk the bigger twin to prematurity. So then we have to do something to protect the bigger twin if in case, because of nature, the smaller baby is going to die. And that is where the in utero treatments come, and the selective feticide, so where you go and stop the blood flow in the smaller twin, so that when the baby dies, there is no problems to the bigger twin. And you can do it in many ways. You can do it ultrasound guided coagulation, or you can do laser, RFA, depending upon what your center is well versed with. And I think in the UK, there are centers who are more comfortable with RFA. There are some centers who are comfortable with laser. In general, RFA is an easier technique to learn, and it's less expensive to implement. So what happens if you have not caught the correct moment, or naturally, without any warning, the baby has died? And that does happen in about up to 7% of pregnancies. So there's a very recent, this month, the systematic review has been published, which has looked at all the studies that have been published on this. And there is a very high incidence of preterm birth less than 34 weeks when one baby has died. And the other baby also could die in about 6 to 10% of them. And the neonatal death is also common. So we have this policy because when one baby dies, the bigger twin rushes to rescue that baby. So in that process, that baby becomes anemic, and then that baby has got cerebral abnormalities. So now we have fetal MRI. So we do routinely fetal MRI after we diagnose single fetal demise. And if you have an abnormal, it predicts the neurodevelopmental outcome. I think the one conclusion from this study is, if one single baby has died, and if you have a normal MRI a couple of weeks later, then you can be more positive about the outcome. And again, when you differentiate this from fetal death due to untreated TTTS or no TTTS, results were more or less same, except that the neonatal death is high in TTTS without treatment. Obviously, because of polyhydramnios, they go into preterm labor and the complications of prematurity. I won't go into the details. I hope my next speaker would cover this. But this is something we look for TTTS, and sometimes this can easily slip. But now all guidelines include looking at MCA, peak systolic velocity, as a routine in monitoring monochorionic. So we shouldn't be missing this. This is where one baby is anemic. This is because of a very slow transfusion through smaller vessels. So they are not frankly TTTS, but slowly one baby becomes anemic and the other one becomes polycythemic. Again, if you suspect, this can be treated with laser, and hence we should actively look for this complication. So I'll now move on to less common problems, but they do happen, is the trap sequence or acardiac twin. So here one twin doesn't have a heartbeat. So the other twin is supplying the, so what happens is the heart supplies mainly blood supply to the head, whereas the blood supply to the lower limb is through the passive blood flow from the umbilical artery. So the lower part of the baby develops, but the upper part of the baby doesn't develop very well. And there are, depending upon, there are a few types that have been described. I can't remember them, so I wouldn't insist you should remember. But because the other twin is giving blood to itself and also trying to rescue the other one, can go into failure, polyhydramnias, and prematurity, and there's a very high mortality rate. So this we can sometimes pick up even from the first trimester. That's why, that's when the first trimester scan has to be very thorough in twins as in singleton, but more important in twins. If you diagnose trap sequence in the first trimester, there was this argument about should we do something about it then, but of course we know that any in utero procedure done before 16 weeks carries higher risk of pregnancy loss, so wait till 16 weeks. Sometimes it sorts it by itself. Both babies die, or a smaller twin, the blood flow stops and the other one grows normally. So people try to see whether we can do it. In Germany, they did try to do it in the first trimester, but their conclusion was the fetal loss rate was very high. So now the conclusion is some people would measure the ratio of the crown length of the pump twin versus the recipient acardiac twin, and if it is 80% or more, then would recommend earlier treatment. Again, you have to balance the risk of pregnancy loss with that. The recent systematic review by Ruano et al. Has again confirmed that you have to intervene, but ideal time to intervene is after 16 or 18 weeks. The intervention has got better survival rate, and the common interventions that are used are radiofrequency, laser, and monopolar cord coagulation has the best results, and cord ligation has got 100% result, but it has been done only in only 8 cases or something. But radiofrequency ablation is something easily done, successfully technical, so most people would resort to RFA. So coming to the congenital abnormalities, we know they are more common in twins because, by the odds and mathematical formula, if you have 2 pregnancies at the same time, even in DCDA twins, it is higher. If you pick up earlier, the earlier you do the selective termination in a dichorionic twin pregnancy, better it is, because you've got a small dead tissue, so less pregnancy loss. If you have missed the boat, other best time to do is after 32 weeks, because you have relatively eliminated the risk of prematurity here, and it's a straightforward method for feticide using potassium chloride. On the monochorionic pregnancy, obviously it needs selective one, mostly on the cord coagulation. So it needs mostly fetoscopic or more invasive management. And the common problems we come across in monochorionic twins is cardiovascular, and of course other genitourinary and CNS abnormalities are common too. So we go for cord occlusion more than 18 weeks in these. So if you have a discordance for abnormality, one baby has and the other baby doesn't have, we have to carefully consider, we have to definitely confirm whether it's structural abnormality or chromosomal abnormality. Is it going to be a severe handicap? Do we have to do a termination? If it's like a mild thing like talipes, you don't have to, because it is a correctable abnormality with better outcome. And sometimes you also have to think about, for example, anencephaly. The problem is, there can be polyhydramnias, which can put the other pregnancy, other normal twin at risk of prematurity. So for that reason, you may want to do an earlier selective termination. And again, you can do expectant management or mid-trimester cord occlusion. In monochorionic, we don't do late termination, but it's more common in dichorionic twins. Next is the mono-mono. There's an increased perinatal mortality reported here compared to diamniotic twins. The most important thing is the first trimester. When you're making a diagnosis, you have to be absolutely certain, because there's lots of false positive and false negative diagnosis. If necessary, do a transvaginal scan. Sometimes if 2 cords come closer to each other, that can look like a diamniotic. Sometimes it's the other way around. You might miss a membrane if you don't do a transvaginal scan. TTTS is less common, obviously, because of the physiological principles. Cord entanglement is there at all stages in pregnancy, but after 32 weeks, it is more associated with spontaneous intrauterine fetal death of one, mostly both the twins. And hence, we are offering elective cesarean section 32 to 34 weeks. There was quite a long time debate about should these women be monitored inpatient to reduce the risk of stillbirth, but I think the French group and Canadian group have published on it, and the outpatient versus inpatient doesn't, so you don't have to restrict your women to hospital in the thought that you would reduce the risk. But none of this is evidence-based, and I'm not sure whether we would ever get an evidence because of the relative rarity of this pregnancy and the very unique presentation of each mono-mono.
2 minutes left.
Okay. Conjoined twins, we all know when it happens later, it's quite rare complication. Again, the best time for diagnosis is first trimester, because you can do a termination without major morbidity to the mother. But if it is late, then you end up doing a C-section with a significant maternal morbidity. This has to be managed in a tertiary center with good neonatal pediatric surgical care. Higher order multiple, I haven't gone, but I would say higher order multiple pregnancy itself is a complication, and it is in the hands of us as obstetricians and gynecologists to prevent it. In the UK, it's extremely rare for us to see quadruplets, or most of the people who we have managed have had IVF elsewhere and came to us. So that is definitely, as an obstetrician gynecologist in this group, I want you to take it. So generally, the incidence is increasing. We have to regulate the artificial conception practices to reduce the incidence. And every other pregnancy is going to have some complications, so be vigilant and start with your first trimester, do regular monitoring and pick up the problems earlier and refer them to specialist fetal medicine center and offer intervention as early as possible. And timing and mode of delivery has to be individualized. Thank you.
Thank you very much, Dr. Sakan, for this neat presentation. We have time for one question. Omar? Microphone.
لا you can use mine.
Thank you for that nice presentation. Just I have one question. We know the timing of delivery for the type 2 or type 1, it's 34 weeks. But sometimes we have the intermittent between type 3 and type 1. How we consider this pregnancy? Type 1 or 3?
I think, if you come across absent and reverse and diastolic flow intermittently, it becomes type 3. It is, if it is less than 30, we err on the side of expectant management. If it is more than 30, we give steroids and Maxelf to optimize the outcome and deliver them. They are challenging, the reverse ones. We go by ductus venosus monitoring in them.
Thank you.
Last question, Dr. Oqba.
Thank you, Dr. Oqba. How would you approach selecting which fetus to do feticide in twin transfusion syndrome, knowing that the procedure can be easy for one and difficult for the other?
Yeah, I think, we work closely with King's, Professor Nicolaidis is of the opinion that even the smaller twin has to be given a chance. So he usually go for placental laser in those cases, and the smaller twin takes its chances. And I have also seen in Europe the practice of going for selective feticide of smaller twin. But then, the bigger twin also has got post-TTTS cardiac complications. There's no win-win. I think placental laser gives the sort of fair chance to both the twins.
My question relates, if you decide on feticide, which one would you go for? Would you always choose the smaller one? Because, if you do fetal laser, for instance, with anhydramnios, you'll be causing a symptoster. But it's easier to go for the larger twin. And sometimes the larger twin has abnormal Dopplers, and sometimes the smaller twin has abnormal Dopplers. Is there an algorithm that you would follow, or you just go for the smaller twin?
I think, because I know mainly the practice with the Kings, where we refer our cases for laser, and 99% of the time the placental laser has gone for, rather than going for a smaller or bigger twin. I know that the individual centers have different practice. I don't know what, I have got my other colleagues from the UK here and from other countries. What does anyone else would do differently?
Thank you.
Thank you very much.
Thank
Yeah. So we're going to move to our third speaker. Unfortunately, Dr. Munir Al-Habli could not make it to Jordan, so we will have her lecture as recorded. She's going to talk about also TTS management and overview of outcomes. So maybe the lectures will be related and we'll have more focus on the management of twins. Dr. Munir Al-Habli, she graduated from the AUB. She's a dear friend to the society. She's been here so many times in Jordan. and she finished her obstetrician and
Good
gynecology
morning. I
degree
would
and
like to
maternal
thank the
fetal medicine degree in Cincinnati College of Medicine. She's now an assistant professor at University of Cincinnati College of Medicine. So we're waiting for the recording. If you are ready.
Good morning. I would like to thank
Can I
the
remind you,
organizing
please
committee,
just
Dr.
keep the
Maher
phone
Mahaika,
silent.
Dr. Abir Annab, and all organizing committee for inviting me to give an update about twin transfusion syndrome. I would like to mention how much it's hard to do a televisit, and I would like to remote the lecture, sorry, and I would like to say I'm sorry and I apologize. I'm unable to come due an injury. But hopefully this will be sufficient. Twin transfusion syndrome is the most common complication of monochorionic twin, accounts for 15% of all monochorionic twins in the USA, with an overall mortality 17%. And if it's left untreated, it's 80 to 100% untreated mortality. The pathophysiology of twin transfusion syndrome is unknown, but it is assumed that there is an imbalance between vascular anastomosis leading to unidirectional flow between the donor and the recipient, and this will lead to a hypovolemic donor where we have upregulation of the renin-angiotensin system, causing a constrictive, vasoconstrictive process, oliguria, oligohydramnios, and renal tubular dysgenesis. And the recipient will have hypervolemia with passes of the angiotensin II from the donor. This will lead to hypertension, recipient cardiomyopathy, polyuria, and polyhydramnios. And this is an image of showing the connections, and this is an image showing the connection between the donor and the recipient. There is 4 types of vascular connection, AV or arterial venous, venous arterial, arterial or venous connection. And this is a picture of a placenta where we have, this is the vein from the donor connecting to the artery above the vein, and this is the anastomosis between both fetuses. The staging that is commonly used is Quintero staging, where we have 5 stages, stage 1, stage 2, 3, 4, and 5. In Cincinnati, we use the Cincinnati staging, where in stage 3 we do an echocardiography and we subclassify into stage 3A, 3B, 3C, which is mild, moderate, and severe cardiomyopathy of the recipient. Management options that are available: either expectant, amnioreduction, medical, laser, RFA, and selective reduction. And I will focus on the first 4 treatment in this lecture. Expectant management in twin transfusion has been reported in the literature in stage 1 and 2 with an 86% survival rate, and the reason because only 10 to 30% progress to a higher stage, and the 3/4 in stage 1 will remain either stable or even regress spontaneously, and thus there is a 5% only of cases in stage 1 and the stage 2 where we have a fetal demise of one or both the twins that can occur without any warning. For stage 3 and 4, there is no randomized clinical trial of expectant management, and the reason there is very poor outcome, 70 to 100% perinatal mortality rate at less than 26 weeks. If expectant management done in these stages often leads to demise at least one twin, and then we will have 12% loss of the co-surviving twin, and 50% neurodevelopmental delay will happen in the surviving twin. What about amnioreduction? Can be done as early as 15 weeks, where we decrease the DVP or the deepest vertical pocket to 5 to 6 centimeters. The aim mainly to reduce preterm labor, decrease intraamniotic and placental vasculature pressure, and this will help improve placental flow and increase uterine blood flow, and thus also decrease the pressure on the venous anastomosis, and that will give them some compensatory function for the donor and for the recipient. A randomized clinical trial has been done to compare amnioreduction versus septostomy, which is a hole in the intertwin membrane. They found that the overall survival in both the conditions is about 60%, and there was no difference in outcome, including gestational age at delivery or complications in both the methods of treatment. Thus, Embryo reduction or expectant management for stage 2 and above are no longer first-line treatment for twin-twin unless laser treatment is unavailable or while awaiting transfer to another center, and can sometimes be utilized for short cervix or early twin-twin less than 18 weeks or more than 26 weeks, but this is case-by-case study. What about laser? As you see here, laser started in 1984, where Delia and Kerr Bernstein have used it in animal studies using the Nd:YAG laser. The first laser in a human one was done at University of Utah by Dr. Delia in 1988, and then 7 years after that, Veal et al. Did non-selective phytocoagulation. What does that mean, non-selective? That means we have an intertwin membrane. Any vessel crossing from the donor to the recipient, this intertwin membrane, they laser it all through. So he reported a few years after that that the results of non-selective laser was similar to embryo reduction with an overall survival 55%, single twin survival 73%, and then when they did placental pathology, they found there was a lot of placental necrosis, and that could lead to the demise of either recipient or the donor. And then in 1998, after the non-selective, Quintero did selective laser and reported certain changes. What does that mean, selective laser? So non-selective, when we have this intertwin membrane and they laser all of these vessels, even if they did not have a connection, that is the continuum for the donor and the recipient. For selective, they only laser those that are connected between donor and recipient. And they found that definitely the result was superior to non-selective, with an overall survival 83% versus 51% in non-selective and 51% in embryo reduction. The first randomized clinical study compared the laser to embryo reduction was in 2004, and it showed better survival in the laser and seen here for one and improvement in neurologic outcome for those that survive. So after this SFLP, randomized clinical trial for SFLP, standard of care in France, stage 2 and above is to do laser. Then 2 years after that, Quintero suggested what's known as sequential therapy. He started his randomized clinical trial in 2010 over 12 years and reported just in 2024. What is sequential therapy? So first, selected when we did all of these that are connected, not this one, this one, this one, and this one. For sequential, is mainly they start with the donor arterial venous vessel, and that would allow blood to go from the recipient to the hypovolemic donor, and then they do the recipient AV, and then they do AA and BB. When they did report their outcomes in 2024, they found that the primary outcome was donor survival, and they had other secondary outcomes as complications, spatial age, and delivery. They found that there was similar donor twin adverse between sequential and selected, and also the 30-day survival was the same for donor recipient for at least one or for both one. Thus, they suggested that the sequential therapy could be effective with the donor to stick abnormal Doppler, or if there is AA between the donor and the recipient. That means arterial anastomosis between donor and the recipient. After this sequential therapy in 2009, and 11, there was a suggestion was known as Solomon. What is Solomon? So the first laser was non-selective. Then we did selective, which is only the connection. Then they started doing the sequential in order to improve survival, but was the same. And Solomon is mainly connecting laser in between those dots. And why they suggested they looked at Solomon, because after the selective endoscopic laser photopopulation, there was a residual anastomosis up to 33%. And complications post-laser was decreased fetal survival, recurrent twin and past twin anemia 45 years procedure. So when they compared the Solomon technique, we looked at the primary outcome, we needed survival of at least one twin, double twin, and also looked at complications. And they found that there is no difference between the Solomon and selective endoscopic laser procedure and survival of the only benefit was that in Solomon, they have decreased in the rate of recurrence of twin and dash and higher rate of latent aberration. As seen here in this figure here in the table, the recurrence rate in the TTS and DAS when we did Solomon was better than when we used selective public aviation, but the complication was the same between Solomon and selective endoscopic laser follow-up aviation. Thus, in summary, selective endoscopic laser is the standard of care for twin stage 2 and above. And whether to do Solomon or sequential laser, this should be individualized assessment and also based on the surgeon level of experience. What about medical management? Medical management has been using similar because of the recipient cardiac failure, as I mentioned in the first of my lecture, and we used the Jackson device, suggested it rating, but was no benefit in survival. In the method that actually showed worsening of survival. And there was only one treatment known as lactocardia or nifedipine that has been published up till now that shows some benefit, and it has been used in patients with twin transfusion syndrome stage 3, A, B, and C, and 4. 20 milligram Q6 hours for 24-48 hours 3 later. And we found that there is significant improvement in overall survival, especially recipient survival. There was no benefit in the donor because donor is not hypertensive, but still the randomized clinical trial is indicated. And just to give a special situation and review what is the management of twin is gestational age and the time of laser impact outcome, and also just report the general outcome of twin life stage. For stage 1, there was a systemic review, recent one, and meta-analysis looked at the primary outcome in those that had laser versus any reduction in stage 1 for survival, and the secondary outcome based on gestation age of the baby and the rate of return of premature children. As compared to laser and expectant management, there was no difference in survival and no difference in gestation age of the baby or the rate of return birth or premature rupture of the baby in stage 1 treated with laser versus expectant management. Thus, the recommendation when the patient with a stage 1 to confident that we do expectant management that there is 50 to 70% of patients could regress, so they need very close monitoring. The overall incidence of neurodevelopmental that has been reported up to now is about 14%, but still there is a lot of data that is lacking in stage 1. But definitely we do laser in stage 1 patients if they have massive immune reduction in general, more than a DBT of 12, symptomatic mild discomfort, cervical shortening or dilation or cervical length less than 3 centimeters, or if there is a progression of the stage from stage 1 to stage 2, 3, or 4 on the other end. Other condition that is always controversial is the timing of doing the laser before 18 weeks and after 26 weeks. There was a recent paper that looked at the role of gestational age at the time of laser in relation to outcome. And they divided the patient by gestational age of laser before 18 weeks and then up till after 26 weeks of gestation. They found that laser before 18 weeks lower survival of aborted twins mainly driven by high rate of donor loss. Gestational age of delivery was not that much affected by the age of laser. There was a higher rate of premature rupture of membrane when it's done less than 18 weeks and higher rate of fetal demise. The general overview, I want to end this lecture with the outcome per stage for twin transfusion syndrome that has done laser. General view is that from the less severe stage, usually they have better survival and less complication of preterm birth and less neonatal complications. So in summary, the lower the stage, the higher the survival. Fetal mortality is high with higher stage. The incidence of preterm birth and neonatal morbidity is increased with the severity of twin transfusion syndrome. Stage 1 has similar outcome regardless of the treatment option, whether expectant amine reduction or laser has been done. Thank you for your time and effort. I appreciate your understanding to give this lecture remotely. Thank you.
Our next speaker is Professor Ranjit Akolika. He's a professor in fetal medicine and obstetrics. He's clinical director of Midway Fetal and Maternal Medicine Center. He's affiliated to Midway Fetal Maternal Medicine Center, Midway NHS Foundation Trust in Kent. Also, he's affiliated to Canterbury Christ Church University. He published 250 peer-reviewed research, and he has more than 27,000 citations with H-index of 70. His research interests include prevention of stillbirth, with particular interest in reduction of complications related to placenta and umbilical cord, and early detection of pregnancy complications such as preeclampsia. He will talk to us about stillbirth in current practice, strategy for prevention. Please, Professor.
Thank you. Good morning, everyone, and thank you to Dr. Anab and Dr. Maita for having us here. So, of course, we've had a wonderful morning with discussion of prenatal diagnosis of cardiac abnormalities that you had a lovely lecture about, and then there was a discussion about complications of twin pregnancies. This is slightly digressing. This is the bread and butter. So what I will talk about is prevention of stillbirths, which is what you and I do every day, which from a fetal medicine perspective, as to how does a good assessment of the fetus reduce the risk of what you and I want to do, which is to prevent adverse outcome, to prevent death. There is a lot of talk about prevention of stillbirths. There is a national policy in England, and this graph shows you the comparison of the stillbirth rate in England compared to its European neighbors. And of course, yes, despite guidelines and various things, the risk of stillbirth is relatively higher in England and in the UK compared to its neighbors. And there are various reasons for it. And again, there are some that I have mentioned on the slide here. One is there are differences in definition of what is a stillbirth. Is the definition of fetal death 20 weeks, 22 weeks, or 24 weeks? The Canadians would define a stillbirth as death after 20 weeks, whereas in England the definition is 24 weeks. And then there are differences in clinical practice with regard to how these scans are done in the pregnancy. If I, for the sake, I'm giving the presentation here in Jordan, so I wanted to look at the data for Middle East and compare the statistics in Jordan to rest of the Middle East and Africa and Asia and Europe. So this is a graph that shows you the comparison of statistics for stillbirth in Jordan compared to its neighbors. So I think when you look at that, the stillbirth in Jordan is relatively good actually. It is much less than its neighbors. It is for sure far less than it is in Asia. It is for sure far less than it is in Africa. But I think more could be done. When I look at the graph, so this is the data on the WHO website that looks at the stillbirth rate in Jordan over the last 20 years. So I did this graph yesterday whilst waiting at the airport. So you can see that there's a significant reduction in the rate of stillbirth in Jordan over the last 20 years, but more can be done. And again, a lot of the academics and a lot of the scientists, a lot of obstetricians within Jordan have published data recently as late as 2020, 2023, 2025. And there is a Jordanian stillbirth and neonatal death surveillance system, and this is one of the recent papers that was published in the last few years that demonstrates the causes of stillbirth in Jordan that relate to causes that are unexplained, causes that relate to congenital abnormalities, causes that relate to placental causes, causes that relate to prematurity. So where does that leave us? So this is not a discussion, all of you are practicing obstetricians and gynecologists, so this is not for me to tell you what is the importance of diabetes and smallness and various things. You all know that and I know that, we all know that. The key here is to change how you think when you risk assess every pregnancy. So a lot of what I'm discussing is change in approach to risk assessment and triaging of each pregnancy, because the vast majority of problems happen, as you heard in the morning from George, that they happen in low-risk pregnancies, and the stillbirths as well. The vast majority of deaths happen in otherwise so-called normal pregnancies. So to concentrate on high-risk pregnancies is missing the point completely. This is the strategy in England that talks about reduction of stillbirths. You could question as to whether how much of it is applicable to your setup and even to the setups in England, because half of the elements of this policy are public health measures with a questionable outcome in terms of how do you measure the impact of reduction in smoking that causes reduction in stillbirths, or the impact of telling women, the midwives telling women at every appointment that, please remember to measure your movements. How do you quantify whether that reduces stillbirths or not? So it is a nice thing to do from an antenatal perspective, but you cannot quantify the reduction in stillbirths. So if I ignore all of that and go back to what you and I learned in medical school and simplify it, that let us look at the list of things that cause a stillbirth. That when you have a stillbirth and how is it reported to the national databases, there are two types of stillbirths. One is those that you cannot prevent, and second is those that you can prevent. And the work that you and I do is to look at the causes that are preventable stillbirths and make sure that those babies go home. And of course, if there is a pregnancy with hypoplastic left heart that is undiagnosed, it will eventually lead to not just perinatal complications, but a smaller proportion are associated with perinatal deaths as well. So one is effective diagnosis of aneuploidy. So if we want to have a strategy for effective identification of stillbirths, we have to diagnose 99.9 or 100% of aneuploidies. So that has to be the case. So every 12-week scan has to be done effectively. It needs to include an assessment of fetal anatomy. It needs to include an effective and robust system of assessment at 12 and 20 weeks. I won't talk any more about the left side of the screen, which is preventable, because this is not a talk on screening for aneuploidies or screening for fetal defects. The key is on the right. And of course, in 20 minutes, it is impossible to cover prematurity and hypoxia and diabetes and cholestasis. But I will focus on hypoxia because that is something that is very common. When you talk about hypoxia, there are two kinds of hypoxia. One is chronic hypoxia and second is acute hypoxia. Chronic hypoxia is gradual reduction in oxygen saturations in fetal blood over several weeks and months, and that is fetal growth restriction and placental insufficiency. Acute hypoxia is you've done a scan today, the baby is perfectly normal with a normal umbilical artery, with a normal growth, with a normal blood flow in the middle cerebral artery, but tomorrow or something else, a week later, the baby is dead because of an acute complication where something happened yesterday night, and that is acute hypoxia. And one of the common reasons for acute hypoxia is vasoprevia. So the question is, can you prenatally diagnose vasoprevia in 100 out of 100 pregnancies, because they contribute to your stillbirths, and we call them unexplained in the vast majority of pregnancies because you never pick it up antenatally. And again, like I said, it is a difference in approach. When every ultrasound scan is carried out, it is important to assess that it is not just focus on the baby, it is not just the NIPT, which is cell-free DNA testing, it is not just the examination of fetal anatomy. Yes, of course, it is important to diagnose fetal cardiac abnormalities and diaphragmatic hernia. But how common is diaphragmatic hernia? 1 in 3,000 pregnancies. How common is stillbirth? 1 in 200 pregnancies. So when you examine the pregnancy, it is important to do NIPT, it is important to examine fetal anatomy. But if you haven't assessed the placenta, if you haven't assessed the umbilical cord, and if you haven't assessed the cervix, you have done only 50% of examination. And therefore it is important at every single scan to examine fetal anatomy, to examine the placenta, to examine the cervix, to examine the cord insertion, because you can diagnose complications that are associated with adverse perinatal outcome in almost every single case. And it ain't difficult. It is easy. It is something that can be implemented in routine practice by routine sonographers, midwives, general obstetricians. All it requires is training and thinking and planning. It is a question of training. If I show you the list of stillbirths, so this is the data from King's College Hospital and Medway Hospital over the last 15 years. So this is the data that we published from the Fetal Medicine Foundation. So this is our own data. So this is us looking at the deaths that have happened on our hands. So these are the deaths in our fetal medicine units over the last 15 years. spread across a vertical axis of birth weight and a horizontal axis of gestational age along the birth weight centiles. And you can divide the deaths into extremely premature deaths, preterm deaths, and term deaths. And on the gestational age, that gives you the distribution, and the centiles give you how many are small and how many are big. It gives you a graphical presentation of how many babies that die that are small, how many are preterm, and how many are term. And the question is, if we are talking about fetoplacental hypoxia, which is the one that is highest in the preterm fetuses? If you look at the causes, even in the data from the Jordanian stillbirth and neonatal death registry, it is exactly the same as Embrace in England, it is exactly the same as any international data. 75% of deaths that happen between 24 and 32 weeks are related to small for gestational age, fetal growth restriction, and preeclampsia. So after going to every single conference for the last 15-20 years where everybody has bombarded you with knowledge about preeclampsia, knowledge about fetal growth restriction, the question to ask is, why are these babies dying then? If you and I are experts in diagnosis of fetal growth restriction, why are 75% of deaths between 24 and 32 weeks happening because of small for gestational age and undiagnosed preeclampsia? They are happening on your and my watch, despite us going to every conference, despite us knowing, and every one of us is an expert in preeclampsia and fetal growth restriction. So why are these babies dying then? They are dying on our watch as well. And the question to ask is there a way of identifying these babies? And yes, one of the things, if not 100%, but a substantial reduction, is combined screening for placental insufficiency at 12 weeks using uterine artery Dopplers, mean arterial pressure. If you are if you can afford it, use placental growth factor. If you cannot afford it, use pregnancy-associated plasma protein, use maternal factors, use an algorithm to calculate the risk, and give women aspirin from 12 weeks onwards. It is a simple thing to do, but it will substantially change the incidence of early onset disease significantly. You have heard this in several conferences, but still it is not routine practice. It is not routine practice, and again, people debate in conferences about 75 versus 150. People debate in conferences about whether we should give it to everyone. Well, of course we should not give it to everyone. I won't go down that road, but the one point to remember is combined screening for placental insufficiency at 12 weeks and to give aspirin to the high-risk group will have a significant impact in reducing the risk of SGA-related deaths before 32 weeks. And the second thing is uterine artery Doppler at 22 weeks. In England, despite the evidence for the last 30 years, if you ask me how many maternity units, there are 140 NHS trusts, how many of them do routine uterine artery Dopplers? Less than 20%. Less than 20%. So it is not about going to conferences and saying that the practice in England is great. It is an international issue. The key is how many of us believe enough in the evidence to implement it in our routine practice. Uterine artery Doppler is 2 minutes of your and my time. And of course, you can stratify the population at 20 weeks into those that require assessments at 24, 26, 28, and 32 weeks, versus those that can be discharged and seen at 28, versus those who are extremely low risk because they have a low chance at 12 weeks, they have normal uterine artery Dopplers, and they can be seen at 36 weeks. It gives you a strategy for following up. Unless you have a small private practice where you see 50 people in a year, well, scan them every day. Doesn't matter. But if you're scanning 1,000 people a year, you cannot do scans 5 times in the pregnancy for 1,000 people. So this gives you a framework for identifying who needs 5 scans, who needs 3 scans, and who needs 2 scans. And with regard to the term stillbirths, of course, we do a routine 36-week scan. We have 5,000, so I work in a public hospital, we have 5,000 deliveries, and we do a 36-week scan for every single one of them. And based on that strategy, we introduced that 36-week scan at King's and at Medway in 2014. And since 2014, we have seen a significant reduction in the risk of deaths related to small for gestational age because we are scanning them, and the babies that are small with abnormal Dopplers are being acted upon by clinicians and delivering them. So that is one of the causes. So there are several advantages of the 36-week scan, but one of the advantages is identification of term SGA. Of course, this is a graph that is for you and I to think. This is not a question, but this is an observation. When we looked at all our deaths at term and saw when do they happen, and this is the risk of death related to gestational age. And you can see that the risk of death is highest when you're 41 weeks and 42 weeks. So you have to ask yourself the question that when somebody says they want to go post-mature or post-dates or post-term, you really have to ask, are you safe to go post-term? Or maybe do a scan at 39 weeks. I will just finish on last couple of points. One is the issue of CPR. There is a lot of discussion about CPR. CPR is an artificial ratio that divides one Doppler with the other Doppler. We don't do that anywhere in medicine. We don't do that with HCG and PEPE in screening for aneuploidies, but we do that because it is something people have done since 1990. CPR tells you what the MCA tells you. If you had a policy, in our unit for the last 10 years, we haven't used CPR to manage any pregnancy, ever. We used umbilical artery as a primary Doppler of management until 37 weeks, and after 37 weeks, we use MCA as the primary Doppler, and it will tell you exactly the same thing that the CPR does. And if you have an effective method of screening at 12 weeks, screening at 20 weeks, scan at 36 weeks, and use these Dopplers accordingly, it will give you the same thing. This graph tells you the deaths we've had at term, and the red dots are the ones with low CPR, and the gray dots are the ones with normal CPR. So how many deaths you can see are related to low CPR? Really less than 5%. 95% of the deaths happen in those that have a normal CPR. So CPR as a strategy to reduce stillbirths is not only poor in terms of detection rates, but it also is very poor in terms of the number needed to treat, because you can see that on the slide and you can see that from the publications. You need to induce or deliver 1,000 people to prevent one stillbirth in normal babies. I will talk about this in the afternoon, so I won't spend too much time discussing it here, but one of the important things is screening for vasa previa, and we'll talk about more in the afternoon. But it is an easy cause it is an easy cause to identify, and we still don't have an international or national policies. There are several papers. I mean, this is the cervical length, this is the cervix, this is an umbilical artery in front of the cervix. How on earth is this baby going to deliver without rupturing that blood vessel and causing severe fetal hypovolemia, exsanguination, and death? And we still are not convinced that this is something that we should check for on every scan. But we have an understanding of screening for, because people are obsessed about the brain and the heart, because it is medicine and therefore it is more appealing. But this is easy. It is a blood vessel in front of the cervix. It takes 2 minutes if you and I know how to scan. And therefore it is an important thing which we will discuss in the afternoon. I will finish on the last 2 slides. This is for stimulation of your thoughts and for discussion at coffee. One of the last elements to be introduced in the prevention of stillbirths is prevention of stillbirths in diabetes. And this is a question for you and I to discuss and do more research on. Why do pregnancies with diabetes have fetal deaths? Is it because they have abnormal placenta? Is it because they have abnormal Dopplers? I mean, there are thousands of papers where you will see that you've had a scan today where the baby is on the 80th centile with mild polyhydramnios, normal umbilical artery, normal MC, and the baby is dead in 3 days. So there are several papers that tells you that there is no association between fetal Dopplers and fetal death in diabetic pregnancies. So is the cause of fetal death in diabetic pregnancies hyperglycemia or is it hypoxia? And if it is hyperglycemia, how do you detect hyperglycemia and identify pregnancies at risk of metabolic acidosis in an ultrasound scan with the fetus? I am happy to discuss later, but it is impossible to address that degree of discussion in a 20-minute talk. But this is my last slide. This is to summarize in terms of a strategy for prevention of stillbirths. Effective screening for aneuploidies. I mean, we have been doing it for 30 years, so there is no reason why in today's day and age, you cannot have a 99.9% detection of trisomy 21, 100% detection of trisomy 18, 100% detection of trisomy 13, 100% detection of Turner syndrome. No reason why we can't have that. There needs to be effective identification, if not at 12, as you heard in the morning, but at least at 20, an effective identification of pregnancies with cardiac abnormalities and major fetal defects. Effective identification of pregnancies at risk of preeclampsia, placental insufficiency and growth restriction, and given aspirin at 12 weeks. Risk assessment at 20 weeks with uterine artery Doppler, a cervical length to identify pregnancies at risk of premature birth, a routine 36-week scan, effective assessment of fetal growth, effective assessment of fetal Dopplers. Don't use MCA selectively. Do it for everyone. especially in the third trimester. And then it takes 2 minutes of your time to check where the umbilical cord is and make sure it's not velamentous and make sure that you don't have a bilobe placenta, which we will talk later in the afternoon. And don't ignore the diabetic pregnancies. And if you do that, 50% of your stillbirths are already reduced. So I'll stop there. It's a quick presentation, and I'm sorry if it felt a bit rushed, but there is so much to cover with regard to this complication in 15 minutes. I hope that that was at least a flavor for what needs to be done. Thank you. Thank you.
Thank you. Thank you very much, Professor, for this excellent presentation. Any questions?
Thank you for the nice presentation. Actually, I have two comments. The first thing is you have mentioned that there are some strategies you are following in the UK to prevent or decrease the stillbirth rate. I want to add 2 points which are applicable to our country, Jordan. The first thing is that we should increase or raise the awareness of physicians about the importance of the NT, the detailed scan, and the follow-up of patients at 36 weeks. Because we are faced with fetuses who are growth restricted in the last pregnancy, who were not detected by their doctors, and which we cannot do much for them. This is the first thing. The second thing is that we should concentrate on training of the doctors who are dealing with pregnant women to be able to pick up the problems which are rise during the pregnancy, so as to be able to refer them to a fetal medicine or to the specialist specialized in this category as soon as possible to be able to save these lives. Thank you.
Yeah, no, I agree. I think my only comment would be that this is a joint discussion between fetal medicine specialists and the general obstetricians. It is for every general obstetrician to be aware that when they see a report from a 12-week scan that does not include an effective screening for aneuploidies, fetal anatomy, and screening for placental insufficiency, that scan needs to be redone. Yeah. There should be no report for 20 weeks that does not have uterine artery Doppler, and that is the standard. I'm telling you that even in England, people don't do uterine artery Dopplers routinely. But again, it is not a question of whether it is England or it is Jordan. As obstetricians and gynecologists, as fetal medicine specialists, we have to set the standard, you in Jordan and we in England, to say there should be no 20-week scan without uterine artery Dopplers. That is the minimum standard of care, and it takes 2 minutes to do it. So why wouldn't you? Especially when you can identify effectively pregnancies that will end in preeclampsia, fetal growth restriction, and stillbirth. And there is nobody who can tell me why it shouldn't be done. And people come up with issues of training and so on and so forth, but the key is for us to be able to demonstrate it needs to be done.
Yeah. May I have a question, please?
Of course.
Do you think that new innovations in AI and genetic testing will be able to reduce stillbirth, especially the genetic testing? The new innovations in
I'm
AI?
trying to think. I do think that there will be a role for AI in obstetrics and in fetal medicine in the years to come. I'm working with one of my colleagues who is a fetal cardiologist with us, who works at Evelina and St. Thomas's. So the presentation that you had from Dr. Haddad in the morning, they are going to use AI to identify and screen pregnancies with an abnormal heart. So can you use AI? So when you have a scan, and eventually, I heard somebody say at one of the previous conferences that the type of ultrasound scanners will be so small that eventually in 10 years from now, you will not need human beings to scan. You will go to a place where they will do a scan, screen the baby from left to right, and an AI algorithm will pick up, is the 4-chambered view normal, is the 3-vessel view normal, and the ones that are not will go and see a fetal medicine specialist. And I think that may be the future. That may be the future. I still believe in the ability of human beings to, it depends on whom you compare the AI with. So if you compare AI with an average trained person, maybe the AI will be better. But if you compare the AI with a human expert, I think the human expert is better because the AI will not be as good. So it depends on where the study is done, who does the study and who you compare it with. It is an interesting question that you ask, because the more AI is used in medicine, I mean, there is no AI today, and we are struggling with discussion about training for uterine artery Dopplers. If there was AI, there will be less people who will be trained in ultrasound scan, because machines will do everything. So the question is, it will have major impacts on training and creation of experts in the future, but that may be the future. And hopefully I would have retired by that time. So thank you.
Thank you.
Thank you very much, Professor.
Yeah.
We'll have a coffee break
For 20
20 minutes,
Yeah.
and we'll be back at 10 past 11. Thank you.
Yeah. Thank you very much.